Dr. Ashwani from Fortis, Jaipur. Dr. Ashwani, are you around?
Sir, good evening and good evening to all. It's
Yeah.
indeed a great pleasure to have this platform for the nice discussion and with wonderful cases. So here is a case of a 41-year-old gentleman who had abdominal pain on 14th November of 2021. There was no clinical obvious localization for the pain, so patient underwent UJ endoscopy, which was normal. Subsequently, he underwent contrast-enhanced CT abdomen examination, and it revealed that there was a 90% thrombotic lesion in proximal superior mesenteric artery. Here is the image of CT. So it was a contrast-enhanced CT, not CT angiogram. So definitely we cannot appreciate well as we can in CT angio. So this is the SMA, proximal part of SMA, and we can see that there is some filling defect. So with this complaint and findings, he was referred to us on the next day. When asked clinically, he was passing flatus, but constipation was there. Abdomen was tense and intermittent pain was there. Serum lactates and total leukocyte counts were normal. On further probing, he gave the history of similar kind of pain, though that was less severe 9 months ago. And at the time, he was managed with over-the-counter drugs. No further evaluation was performed, and he was a chronic smoker. So with this, we were at the point of conclusion whether to go for PTA versus thrombolysis, catheter-directed thrombolysis in this patient based upon the report of the CT. So we planned that first we will do the angio and then we will decide our plan. So here are the images of digital subtraction angiogram. We can appreciate on the left that the celiac trunk was normal, and in superior mesenteric artery we can appreciate that there is a lesion beginning from the ostium. It is a smooth lesion, no contrast staining is there, no obvious shouldering effect is there. It looks as if the lesion is chronic. It's just like a stable coronary plaque. He also underwent coronary angiogram, which was normal. So now, after the angiogram, the lesion in proximal SFA was significant, but it appears to be chronic angiographically. And the patient was altogether not having any history of cytophobia or something else which suggests that it was a case of chronic mesenteric ischemia. Now, for further management, we thought that intravascular imaging might be helpful in deciphering the puzzle of chronic lesion causing recurrent acute symptoms. So the IVUS was performed. This IVUS is after around 50 millimeter beyond the stable plaque and after two branches. So this is the second branch. We can appreciate that lumen is normal and the diameter of the vessel is around 6 millimeter here. As we are coming proximally, we'll just see that there is hanging thrombus. So here is a visualization of the thrombus. It's freely hanging into the lumen. It is looking like fibrofatty plaque, so I'll say that it is more of the platelet-rich thrombus, which is seen in the cases of acute coronary syndrome as well. Here it is extending into one of the smaller branch, and now it's approaching towards the wall of the vessel. So we can say that here probably it is attached to the vessel wall. Distally it was freely hanging. As we are moving more further proximally, otherwise the vessel structure is totally normal. We can appreciate that it's a trilaminar structure of the superior mesenteric artery. As we are moving more proximally, the thrombus is possibly attached to the one side of the vessel wall. Otherwise, the underlying vessel is normal. The cross-sectional area of thrombus is increasing now. And this is a branch just at the distal edge of the lesion. And now it is a chronic stable lesion. We can well appreciate that the lumen is too narrow here. This is probably some neovascularization channel in the vessel. We can also appreciate that the the diameter of the vessel is decreasing here, suggestive of a negative remodeling. The luminal area is too low here. Hardly any space is left after the catheter. And we are moving towards the ostia. We can appreciate that the significant negative remodeling is there. And we are now just at the ostium of the superior mesenteric artery. Possibly there is some calcific plaque beneath. So I'll just discuss the findings through the still images. So the lesion was from ostium to here. It was angiographically around 38 mm in length, and beyond that, here are the two vessels. So here are the still images at the level of the hanging thrombus. This thrombus is extending into the branch here. More proximally, this is the branch just at the distal edge of the plaque, and more proximally, we can appreciate that there is significant negative remodeling of the vessel. So at that moment, considering that the lesion is around 38 mm in length and the hanging thrombus is there for around another 40 millimeter beyond the lesion. So now whether to go for stenting or for thrombolysis. If we go for stenting, then the problem was that this thrombus was supposed or definitely was supposed to embolize distally, creating much more problems. So we thought that we should go for a CDT first, thereby we can reduce the thrombus burden and can easily take care of the plaque. When we advanced the 6 French guiding catheter, MPA catheter, there was significant pain. So we reduced to 5 French multi-hole MPA catheter. We parked the MPA catheter there and CDT was started with the streptokinase in evening hours. However, the pain was persisting and it was not responding to shots of opioid analgesics. He was started on a tramadol infusion, but no relief in the pain, and even the abdomen was more tense than before. So after 2 hours, we thought that the persistent pain is either because of distal embolization or because of reduced flow even with 5 French MPA catheter. In both the case, if we take care of the proximal lesion, the distal flow will increase and we will have the gratifying results. So after 2 hours, we advanced the catheter. We changed the sheet to the 9 French sheet and 8 French catheter was advanced. It is the distal runoff. IVUS was again performed after 2 hours of thrombolysis. And here is the inner one are the old previous images and outer one are the images obtained after thrombolysis. So we can appreciate that the vessel was normal at the distal two branches, and proximally also the thrombus has resolved up to good extent. It was resolved up to 10 mm in length. We can't say whether it was resolved or it was resolved plus thrombolized, embolized distally. And proximally, otherwise the same thrombus burden was there and the same was the lesion. So at that moment, we took an self-expanding stent of 80 millimeter in length, considering the total lesion length of 70 millimeter. It was deployed. However, there was geographical miss. It was post-dilated. As soon as it was deployed, the pain abdomen got resolved, suggesting that possibly it was the reduced flow which was responsible for the persistent pain in the given patients. So after dilatation, we took another small stent of 15 millimeter in length so that we can cover the ostium. However, we had to put in significant efforts in advancing the proximal part of the stent, and in that attempt, we can appreciate that there was flaring of the distal edge of the stent as well as flaring at the proximal edge of the stent. Now the situation was that we were not able to advance it, and we were not able to retrieve it into the guide catheter. We can also appreciate that now the balloon has started freely moving. So basically there was deglobing, impending deglobing. At that moment, we took the snare and we encircled and confirmed the proximal edge of the stent in the snare. We took out the snare, we took out the stent en masse. Around 75% of the stent could be taken into the guiding catheter. We can see that there is deformation of the stent as well, and the stent was taken out. Now again the post dilatation was performed with the 8 mm balloon, and then another 15 millimeter balloon expanding stent was advanced. Now we wanted a precise localization of the stent. That's why we took the balloon expanding stent. It was expanded with the same balloon. First flaring was performed, and later on post dilatation was performed with 8 mm balloon. Even with 8 mm balloon, what happened that the shaft of the balloon got broken while.
Dr. Sharma, you have last 2 minutes.
Okay, madam. The shaft of the balloon got broken while we were taking it back. So we had to pick everything and mass. I mean the balloon and the wire. And our whole focus was on the balloon. So accidentally this sheet also came out. And on the table, and then later on in situ, we have to give the compression for around 2 hours to achieve the hemostasis. So in the given case, the take-home message is that the diagnosis of acute mesenteric ischemia is usually delayed, and almost in all the cases when the patients come to us, it is in advanced stage with the gangrene, and we don't have any other option other than the laparotomy and colectomy. The intravascular imaging help in deciphering the enema of acute presentation by chronic appearing the lesion. And not only this deciphered this enema, but also it revealed the classical atherothrombotic lesion in the ischemic, which we usually read in the coronary vessels. And the patients, along with the good equipment, is the cornerstone in handling the nightmares. Thank you.
Well, thank you, Ashwani. This was a remarkable peripheral intervention. And I tell you, I have done few SMAs. It's not an easy ball game to plan and execute SMA stenting. It's a totally unsupported vessel. Stent has no support from outside, and
Yes.
that and sizing the vessel and putting a stent is not an easy ball game. So I think you did quite right. My only different way of handling probably is if you did thrombolysis, right?
Yes, sir.
So after 2 hours of thrombolysis, you again checked it. I think it should have been more, 24 hours. So then you really come to know the exact resolution of a thrombus. You mentioned that resolution happened, but I mean after thrombolysis, continue giving heparin and then check if patient symptoms are not. If the patient is continuing to have abdominal pain, where your gastroenterologist always is saying that his intestines are at risk and they are becoming gangrenous, then you don't have an option to try to relieve that ischemia. But otherwise, if those symptoms are settling down and your gastro guys are in sync that we can wait, giving thrombolysis, giving heparin, checking for 48 hours, maybe becomes highly risk there. But even your case, as you are mentioning, the abdominal pain was continuing and it was quite severe. So I think it may be a right approach then. One more thing. So these self-expanding stents have a tendency to miss out on the ostia because you can't be very precise with the self-expanding stent.
Yes, sir.
So whenever you wish to cover the ostia, go for a balloon mounted stent. Like in second case, I mean, which the stent which got disfigured, deformed, you are again trying self-expanding one more stent, right?
Yes, sir.
So I think from the word go, because it was a very narrow segment, hardly maybe 10 to 12 stent is required. So at the ostia, then a small stent just go because whatever precise uh, placement you can actually attain with balloon mounting, you can't do it precisely with the self-expanding. So these are my views of SMA. SMA, and mostly I tell you, even if it is a atherosthrombus, it is a thrombosis of the vessel which is a culprit for uh, for intestinal symptoms. It could be superimposed on atherosclerosis, but if you get away with thrombosis with anticoagulants, with thrombolysis, I think patients may do. But given the choice, if the situation demands it, it's a very good case done. But I tell you from my experience of dealing with few SMAs, it's not an easy ball. It's a tough ball. Any comments from Paul or? Yeah.
Sir, as you rightly said, I think I'd like to second that. Maybe it was a little premature to stop CDT. Catheter-directed thrombolysis needs a little bit more time. and you should have waited for 24 hours. Maybe you would have seen the whole thrombus gone away and then taken a check shot, and it would have saved you from doing an intervention, then landing up into these problems. Second is, as sir rightly said, we have also, I would say, hardly less than 10 SMA interventions that we have done in these last 11 years. There are critical lesions, calcifications we usually see in Takayasu's a couple of times. But usually, SMA does not have very critical calcific lesions unless a patient is heavy smoker and you see atherosclerotic. Otherwise, it is primarily thrombotic occlusions that you see, and mostly they are cardioembolic. What we have seen primarily at our places, embolic occlusions in atrial fibrillation patients. And sometimes they have gone into the splenic artery also, which is very common. So I think you can wait in CDT and maybe continue infusion and then do it after 24 hours. So,
So your point is very well taken, sir. In this patient, when we our first challenge was that whether to go femoral or through the brachial, because we know that SMA is having an acute angle, and that acute angle is responsible for most of the SMA cases to be embolic in origin, while the IM is at 90 degree lesion. So most of the time these are the atherothrombotic lesion. But going by the CT findings where it was thrombotic lesion, we thought that possibly it will require a CDT. And as it is significant, we can't go for systemic thrombolysis. Rather, focused thrombolysis will be more effective. That's
it
why
has
we
to be CDT. There is no
more.
point of there's more to a point of systemic embolization. If
Yeah.
if you have to treat this lesion, it has to be CDT. We can't discuss
Yeah.
systemic embolization.
Yeah, but
that
what
that
happened
is
that
very
you,
clear. That is very clear.
yeah, we
That
started the CDT at 5 p.m. and it was just 5 French MPa. But for the next 2 hours, I was just around the patient because altogether there was no relief in symptoms. The family was in gross agony. He was just 41-year-old gentleman, and I was appreciating that the abdomen was getting tenser and tenser, and the pain was not altogether relieving. If I could have continued the CDT, possibly it was going to land into the.
I would like to share
Gangrene.
something with you. We have done CDT in 2 cases, SMA, and pain has nothing to do with clot dissolution. Pain occurs at the inner level, so it is even in chest pain. You may have a TIMI-3 flow, you'll still have chest pain at microangiography level. So you should not be worried whether the patient is having pain or not. You demonstrate flow has come back, you can wait and then treat them with analgesics. Pain is not the ultimate that it will tell you whether ischemia is there or not, because this thrombus is ultimately going to go to the distal vasculature and it's going to create a little pain. I think that pain should not be the only we should direct.
I think that way it has to be in proper discussion with the gastroenterologist.
Absolutely.
And the lactate levels. So lactate levels have a huge role to play here. Any intestinal necrosis happening, the lactates would go up sharply. So if at all you have to monitor what is happening with the intestine, you keep monitoring it with lactate levels. So
sir, a couple of times we had flank pain, patient having, we started off with SMA CDT and patient having left flank pain. Then you finally come to know that it is going right and left. So these showers are going to go right. They'll settle down. You have to give adjunctive heparin, all these things, and then wait for 24 to 48 hours. If you are clinically stabilizing, there is no need of checking early. Check a little late.
I think have a gastroenterologist on your side, and if your gastro guy says that maybe he's having pain, but we can wait, then wait.
Yes.
And monitoring wise, I'm telling you the lactate levels are of big.
Absolutely.
So I think for the sake of time, but very good, very well done, Ashwani. Very well done. It was a exotic case,
Yes.
and the good point is such type of cases are rarely presented. So nobody is talking of SMA. We discussed so many points about SMA. So very well done.
Excellent.
I would like to give one input, sir, nice input from your side regarding the pain. But in this patient, as soon as we deployed the first stent, the pain was totally relieved. So at least retrospectively,
given your scenario, I think, given your scenario, the patient scenario, I think that was a point which was well decided and well executed by you. We are just discussing that because it's a complex intervention. I think the call should be taken in sync with the gastroenterologist. That's what I felt after doing few SMAs. is not an easy ball game. And obviously, you are trying to protect the intestine. And also, I tell you, if the intestinal gangrene sets in, it's a
Absolutely.
extremely poor prognosis for a patient.
Yes, sir. It was under gastro surgery, and me. The team was working for the given patient.
Okay, great. Great. Let's move on to the next.
Congratulations.
Dr. Hariom Tyagi from Meerut. Oh, sorry, Dr. Raghav Sharma is here. And Dr. Hariom, I think you were assigned discussant here, so you will be assigned discussant.
Sir, I have a presentation myself. I have to go offline. Can I take your leave, sir?
Sure.
And sir, we saw your case yesterday. MVR.
Yeah.
Done, sir. Congratulations.
Thank you.
It's really inspiring when you see such things being done. Great.
We've quite number of structural, and I'll keep on sharing and keep
Thanks a lot,
the intricate points about that. Thank you.
And Dr. Raghav, I'm sorry. Hi, good evening.
Hi, sir. No issues.
For 5-10 minutes, and then I might. Congratulations once again. I know it will be a beautiful case. You never.
Thanks, Dr. Call. Thank you.
Thank you, sir. Thanks a lot. Thanks. Always an honor. Thank you.